And so to introduce Dr. Ugochi Akoma, she is both a general, she's a specialist in both general obstetrics and gynecology, as well as maternal fetal medicine. And so that means that she has additional qualifications and training for high-risk pregnancies. She's really skilled at what she does with over 20 years of experience, spanning across special interest in women's health and high-risk pregnancies and childbirth. She's passionate about providing the highest quality of care to women who have medical, surgical, obstetrical, fetal, and genetic complications in pregnancy. While she is based in the United States of America, and so is joining this call at 6:30 in the morning, her time. Thank you very much for that. She is very closely related to care in Nigeria and understands our context. She did her research project on this topic, co-managing diabetes and obesity, and so is very well fitted to give this presentation. I would, with warm regards, and with privilege, invite Dr. Ugochi Akoma to share her screen and take us through her presentation. You're muted.
But now?
Yes, we can hear you now. Thank you. Over to you.
Hello, everyone. Thank you so much for your time today. I really appreciate all of you. So today we're going to focus on obesity and gestational diabetes. So first, we're going to talk about obesity. So today we're going to focus on the physiologic changes with obesity, the cover classifications and Institute of Medicine guidelines, antenatal complications during pregnancy, intrapartum and puerperal complications, and management strategies and guidelines for obesity, and then as well with diabetes. Obesity is associated with multiple hospitalizations, long stays in the hospital, maternal and neonatal ICU admissions, minor complications like wound separation, endometritis, and urinary tract infections. Also blood clotting, heart disease, strokes, type 2 diabetes, certain types of cancer, specifically endometrial cancer. And obesity is a leading cause of preventable death. One second, guys. The computer froze on me.
Oh, we couldn't hear you for some time, but we, if you could speak now, then I'm sure we can hear you.
Sorry, my computer froze on me, guys. I have to restart my presentation.
Oh, okay, okay.
So how do we calculate body mass index, BMI? We need to know the weight in kilograms and the height in meters. That is weight over kilograms and meters squared. Once the BMI is calculated, you will know what complications the mom is at risk for based on the BMI. This table basically shows us the BMI categories with respect to weight class. People who are underweight are below 18.5, normal weight between 18.5 and 24.9, overweight 25 to 29.9, and obese is greater than 30. And then on the bottom breaks down obesity by classes. Class 1 is obesity between 30 to 34.9, class 2, 35 to 39.9, and class 3 is above 40. What's not on this table is class 4 obesity. Not really a full category yet, but it's BMI greater than 50 or super morbid obesity. It is very important to calculate the BMI in the first trimester or even the pre-pregnancy, because that specific BMI in the first trimester or before pregnancy will have significant implications on the management of the pregnancy. Now specifically to obesity in pregnancy. According to the CDC, in women of childbearing age, about 30% of us are obese, and about 56% of us are overweight, and about 1 in 5 pregnant women is actually obese. There's probably more in this side of the globe. According to the Institute of Medicine, there are specific recommendations for appropriate weight gain in pregnancy depending on people's weight status. As you can see, look at the focus on the row on the right, the column on the right. Underweight women should gain between 12 and 18 kgs. Normal weight women between 11 and 16 kgs. Overweight women between 7 and 11 kgs, and obese women between 5 and 9 kgs. For our super obese mothers with BMIs more than 40, definitely advise them to be less than 5 kgs as much as possible. And for each of these moms that are obese or overweight, at each visit, we have to really encourage them and applaud them for trying to stay healthy, and really encourage them to, as much as possible, stay healthy, keep active, and not gain more than 5 kgs for the whole pregnancy, because it will really help their pregnancies in the long run. According to the Institute of Medicine, also, they have the specific caloric requirements based on weight status. So as you can see in the column on the right side is again, in first trimester, for women that are normal weight, they should have 0 caloric increase. For obese moms, the same thing, 0 caloric increase. In the second trimester, however, normal weight moms should increase their calories by 250 to 350 calories, and obese moms between 1 and 200 calories. In the third trimester, normal weight moms should increase calories by 500, and obese moms by 200 to 300. So one thing that is a myth out there that we're supposed to eat for 2, there's no eating for 2. At the most, you can see that people who are normal weight should only have 500 more calories per day, and obese moms 300 calories a day. So remember, let's break the myth. No one's eating for 2. It's important to calculate the amount of calories we should eat daily. It's very easy to calculate the calories because we need to know several things. I have an acronym that I use, voila. It's weight, age, height, and level of activity. If you know how many calories you should take in every day, you can advise your patients appropriately. And if you all need help with this, please send your patients to mDoc, where they have access to nutritionists who are very, very helpful actually in teaching them how to eat right and count the calories. Just to go over a few common favorite foods that I like that are African or Nigerian, or actually generally, but a whole carrot, it has about 50 calories, a medium-sized orange, about 80 calories, apple, 100, banana, 120, a slice of yam, and it depends on the width of the yam, not a gigantic yam, a small linear yam, one slice, 2 centimeters is about 200 calories, a cup of cooked rice, measured cooked rice, 300 calories, 1 cup of beans, 300 calories, of curry, 400 calories, 4 slices of fried plantain of 500 calories. If you boil the plantain, 4 slices of it is about 300 calories. So as you can see, we're eating a lot of calories per day. We can control caloric intake, we can control overall weight. And the goal for super obese moms, like I said before, is to gain less than 5 kgs for the whole pregnancy. And various studies have shown an overall benefit and a decrease in adverse outcomes like macrosomia, preeclampsia, C-section, and overall adverse outcomes. It is important to know that with obesity, there's a very strange association, because you can have either a really big baby or a really small baby, but it's I guess hit or miss, but it's very common in both situations to have a big baby or a small baby. All right, so what about pathophysiology, okay? So we need to think about obesity as a true medical problem and a significant risk factor for many, many chronic diseases. So excess fat tissue creates an environment of local and systemic inflammation. And it's this inflammation that causes the pathology associated with obesity. So what about obesity in pregnancy? So as I said before, excess fat tissue causes inflammation, which causes significant diseases and diseases for the mother and the baby. Unfortunately, I said the baby because of the mom is being affected as well as the unborn child. Moms are at increased risk for preeclampsia, C-section, diabetes, and in her lifetime, she's at risk for hypertension, diabetes, high cholesterol, and cardiovascular diseases like heart attack. Babies are at risk for having low APGAR scores, NICU admissions, macrosomia, preterm delivery, and as they become children into adulthood, they're at increased risk for having obesity, diabetes, metabolic syndrome. It's also important because many studies are now coming out to show that babies who are obese and have obese mothers are at increased risk for behavioral disorders, ADHD, and poor emotional control. And from my experience, I often recommend that these extremely obese moms be managed in a tertiary care environment with a pediatrician present at delivery. And I also want to mention that because there's a lot of moms who ask, so what about the father if the father's obese? Yeah, if the father's obese, that's a genetic predisposition for the child, but it's actually the maternal obesity that what causes the baby to actually have fetal programming, inflammation, and the lifelong damage. So this study here was done to determine whether obesity is associated with certain OB complications. They found that obesity is significantly associated with hypertension, diabetes, preeclampsia, macrosomia, shoulder dystocia, C-section rate, everything pretty much. Obesity is also associated with increase in fetal death. This study compared normal weight women to obese women, and they found the possible contributing factor, like I said before, is inflammation and potential dysfunction. As you can see, looking at the weeks of pregnancy, the risk of fetal death increases as the pregnancy increases, as the gestational age increases. So let's look at 37 weeks here, right? At 37 weeks, you have 3.5, and at 40 weeks and greater, it's 4, so almost a full point as the pregnancy progresses. From this data and others, we have concluded that the best time to deliver a mom of an obese woman is at 39 weeks due to the increased risk of stillbirth. And from 36 weeks, where the ratio gets even higher for stillbirth, moms should have weekly or even more frequent antenatal surveillance with the doctor. All right, so the primary objective in management of obesity during pregnancy is weight loss prior to pregnancy. Again, prior to pregnancy. We need to reach these women before they get pregnant and stress the fact that prevention is better than cure. Prevention of obesity allows for the best chance of breaking this vicious cycle of maternal and fetal complication. And it helps to eliminate the short-term and long-term complications that mothers unknowingly cause to their children. Because no mother, good mother, would want to cause their children any of the things like you see in this section: metabolic syndrome, obesity, high cholesterol, and all I said before, behavioral problems. So I'm a perfect example of this. Losing weight is extremely difficult. It's affected by so many things. Socioeconomic status. So if you have a lot of money, you have more access. If you don't have a lot of money, you have poor access to foods. Race, marital status, genetics, age, eating habits, and mental health. Because even if you have all of the above, if you're sad and depressed, you may have trouble eating, or you may eat too much. Everything is relative. I do advise, again, that your patients sign up with mDoc because mDoc has full support, nutritionists, coaches, everything, so they can help them with this lifestyle journey. I also want to stress breastfeeding, and I know it's not really a big problem on the continent, but breastfeeding is very important because if you do for at least 3 months, it's been shown to be associated with lower weight gain and lower BMI over the years. So in 10-year study follow-up, moms who breastfed for at least 3 months showed that they gained less weight over time. And of course, it's important to note fertility. So people who are obese have decreased fertility, and losing weight and adopting healthy lifestyle can improve pregnancy rates. Vitamins. So during the preconception period, we must encourage our moms to take vitamin supplements. And I know you all do that because we all do that us here as well. It's important because the poor little tiny embryo, like I said before, is in a pool of hypoxia, hyperglycemia, and inflammation, and it needs all the help it can get to develop normally. I'm sure that you all have prenatal vitamins, and in the vitamins that you give them, look at the back and make sure that it has all these ingredients. I'm sure that it does not have enough folic acid, and folic acid is important because it helps with congenital malformations, okay? It reduces the risk of having congenital malformations. And these moms that are super obese need to be on at least 4 milligrams of folic acid. So in summary, obesity management, nutrition, exercise, and weight loss, and that's where mDoc comes in. Tell patients that they can get pregnant easier if they lost weight, and check on the multivitamins. While they're pregnant, I highly recommend low-dose aspirin, baby aspirin, 81 milligrams, not the full 325. Early screening for diabetes and doing an anatomy ultrasound, because remember I said before, inflammation, hypoxia, high blood glycemia causes birth defects. And these babies should be measured serially throughout the pregnancy because of the risk for macrosomia. And because of the risk for fetal death at 36 weeks, weekly fetal surveillance, where you do ultrasounds or cardiac monitoring. And definitely I recommend in moms that are BMIs more than 40 or even more than 50, seeing them around 32 weeks. And definitely consider delivering by 39 weeks, but definitely no more than 40 weeks due to the risk for stillbirth. Postpartum, encourage our moms to breastfeed, again, because it helps with weight loss, and then continue with the preconception list above. All right, so last but not least, baby aspirin. Very, very important. 81 milligrams low dose. A daily baby aspirin, it improves outcomes in women who are at risk for pregnancy complications and diseases caused by placental abnormalities. And remember I said obesity is a state of placental dysfunction, hyperglycemia, hypoxia. As obese moms are at risk for high blood pressure and preeclampsia and fetal growth problems, it's advisable to start this aspirin at 12 weeks. And definitely, if you can't see them by 12 weeks, at least by 16 weeks, because you want them to be on this aspirin during the time that the placenta is being developed, okay? Lots of benefits. All right, now on to diabetes. So over the next half, we're going to focus on the definition of diabetes, physiology of pregnancy with diabetes, and updates on screening, diagnosis, antepartum, and postpartum management. So, of importance, 6 to 7% of all pregnancies are affected by diabetes. Of these, 15% are pregestational, meaning type 1 or type 2, and 85% are gestational. Some risk factors for gestational diabetes are advanced maternal age, obesity, history of gestational diabetes in the past, or history of having a large baby or macrosomia. So this bar graph will show you that the older the mother is, the more at risk she is for having diabetes. So here we see the younger moms and then the older moms, right? As we get older, the risk increases. Next, we have the bar graph showing the BMIs. So as discussed in the first half of this talk, the more obese the mom is, the more at risk she is for developing diabetes or pregnancy. And here we have the BMIs and the risk for diabetes. So some of the complications of gestational diabetes for the mother: preeclampsia, infections, C-sections, and other long-term sequelae like future diabetes. The baby can have growth problems, remember, either big macrosomia or small, growth restricted, polyhydramnios or excess amniotic fluid, fetal death. And the neonate is at risk for birth injuries, respiratory distress, low blood sugars, seizures, and all other kinds of problems. So how do we screen for diabetes? We can do clinical history, we can do risk factors, or we can do lab-based testing. But the best is lab-based testing. So obesity, diabetes depends on several things. High risk factors or low risk factors. The high risk factors is obesity, family history of diabetes, glucose in the urine, or past OB history, right? Previous diabetes, previously had a big baby, or previously had a stillbirth of unknown reasons. Low risk factors, young age, and BMI less than 25, no history of diabetes, no family history of diabetes, not in a specific ethnic group, and no adverse outcomes. Like I said before, since more than half of patients with diabetes have no risk factors, it's advisable to screen all pregnant women, all of them, even if they have low risk factors, higher, but no risk, to screen all of them. So lab-based screening is what I definitely advise. So it's done either of two ways, but this is the way that ACOG, American College of OBGYN, recommends. We do a 50-gram 1-hour glucose challenge test. The patient comes in, can be non-fasting, she gets a drink, and an hour later, we draw blood sugar. It's done arbitrarily between 24 and 28 weeks, and there are two thresholds that we use. We use 140 or 130. I sometimes am confused, so I use 135 because I think that we miss people with 140, and we screen too many people if we use 130, but we can choose either number, it's fine. In high-risk patients, if you don't have access to this 1-hour glucose challenge test, for affordability's sake, I do advise that starting in the first trimester, please screen these women with hemoglobin A1Cs, and do it every single trimester, okay? To make sure it's less than 6. And if you can't have access to hemoglobin A1C, you check the random or the fasting blood sugar in the office, have them come in at least once or twice per month and treat them every few weeks to check this, okay? Because many people with diabetes, one time you see them in the office, random blood sugar, it may be normal, or even postpartum may be normal. So it has to be checked serially, okay? And the important time to check is not at the beginning of the pregnancy. Honestly, if you're going to do the serial screens, it's after 20 weeks because the placenta is what causes the diabetes in pregnancy. And after 24 weeks and 28 weeks, the placenta is very, very massive and can secrete all these hormones that cause diabetes. So checking them serially around 24 weeks to 32 weeks is very, very important. So what if the mom fails the 1-hour test? She must do a 3-hour test. The 3-hour test is the fasting test, and it basically tells you that the mom is confirmed to have gestational diabetes. And these are the values that we use to confer abnormal tests. So you can have 2 abnormalities in this screening to be considered diabetes. However, if you have 1 abnormality, it's associated with still all the adverse outcomes, just less, but still associated with macrosomia, shoulder dystocia, and all the other complications as well. So how do we manage gestational diabetes? Diet and lifestyle, number one thing. So diet, even in life in general, any medical problem, diet and lifestyle. And if that fails, then of course, medical management. So the glucose should be monitored 4 times a day, fasting, and then 2 hours postprandial. Some people also do 1 hour postprandial, and that's fine. The better the blood sugar is, the better chances you are for having a successful pregnancy with lower risk for bad outcomes. So looking at the fetal weight, with respect to glucose control, the better your sugars are. Look at this. If you have bad sugars, look how high your risk for macrosomia is. A better control, 12%. Hypoglycemia, the same. And C-section for dystocia, the same. So the better your blood sugars are, the better chances you are for having lower risk for complications. All right, like obesity, diet is very, very important in managing different adverse outcomes. Remember the acronym I said before, WAHALA. Weight, age, height, and level of activity. We must encourage our patients to maintain a good weight. We cannot affect age, we cannot affect height, we can affect level of activity. So weight and level of activity. And the way to increase and mitigate how much you move or not is by what you eat, okay? So here on the right side is a pie graph, which tells us the amount of calories we should have for the whole day. 30 to 40% of our calories should be from fats, good fats, like nuts, cashews, almonds, pears, olive oil. 40% should be from carbohydrates, good ones, like brown rice, brown breads, grains, yams, gari, and 20% protein, beans, fish, even chicken. Okay, and I'm not saying to eat a lot of it. Remember, I said before, portion control, and I gave you guys a few slides ago the portions that are appropriate. Excess, you're going to have excess calories for the day. All right. So again, remember how your patients go to the mDoc platform. So you have access to a health coach to help them with all these things: fitness codes, nutritionists, and lifestyle modifications. So in summary, they should have serial urine cultures because moms with diabetes are increased risk for urinary tract infections. Hemoglobin A1Cs every single trimester, including the A2, which is the for medicine. And if you can't have the A1Cs, I recommend fasting or random blood sugars. If unavailable, traditional screening visit at your facility. And lastly, blood pressure, weight, you do it always, monitoring blood glucose, and regular physical activity. I do want to mention strength training is important in addition to, increasing walking, because the more muscle mass you have, the lower your blood sugars will be. So we tell our moms to try to do strength training in pregnancy. I'm not saying bench pressing, but light weights at least 2 or 3 times per week. Now moving on to medical management. So the first line of care in poorly controlled diabetes is insulin. There are various types of insulin, which can be short-acting or long-acting, and those depend on the trimester and the mom's weight. And this is this chart I have here. This basically specifies all the types of insulin that we prescribe here, and the duration of action, the peak of action. And if you have any questions about this, we can talk about it offline. So if the patient declines insulin or it's too expensive, they still need to be treated, okay? So we must give them something to control their blood sugars. The first line is orals. If they, the second line is orals if they do not want insulin, which is first line. And I usually prescribe glyburide or metformin. They're both safe, but they both cross the placenta and have unknown long-term fetal and neonatal effects, but they both have high failure rates. But they're both pretty good options if insulin is not available or the mom declines taking insulin. So just to compare insulin to oral meds, as you can see, the glyburide is an increased risk of macrosomia and neonatal and maternal hypoglycemia. And with metformin, the only good thing with metformin is that if you're on metformin, there's less maternal weight gain. Otherwise, it has a higher failure rate, and babies can be born prematurely. That's why if I have to choose, I put my moms on glyburide and they decline insulin. So again, ACOG says the first line should be insulin. It has the highest safety profile with a very, very long history. But if we don't have a choice or the mom is declining, we should give them glyburide or metformin. I didn't give the doses, but glyburide, you start at 5 milligrams and go up to 20 milligrams. And metformin, I should start at around 500 to 1,000 milligrams and go up to no more than 2,500 milligrams per day. In regards to management and timing of delivery, moms who are diabetic should get ultrasounds for fetal growth assessment because, again, macrosomia is very, very prevalent. They should get antenatal testing. When your diet control and everything is going well, then I would say ultrasounds serially and at the end of pregnancy to get a weight estimate and deliver no later than 41 weeks, again, because of the risk for stillbirth. With diabetes or medication, we call that A2, or poorly controlled diet, who decline medicine or is not compliant. I will do testing on the baby with ultrasounds and CTGs once or twice a week for 32 weeks and deliver them by 39 weeks. And honestly, in some situations, I've delivered moms at 37 weeks with poor control because the risk for stillbirth is really, really high in moms with diabetes. So depending on the fetal weight at term, there can be a very high suspicion for macrosomia. If macrosomia is suspected, a C-section is definitely advised to reduce the risk or incidence of brachial plexus injuries. So as we can see in this chart here, risk of dystocia is 12% at 4,000 grams, 16% at 4,250, 27% at 4,500, and 35% at 4,750. So the more the weight is, the higher the chances for having a shoulder dystocia. So for that reason, ACOG recommends that if the fetal weight is more than 4,500 grams, to reduce the risk of birth injury, these moms should be offered C-section. In my practice, again, due to the risk of dystocia, I recommend C-section. I counsel them at around 4,000 grams, and around 4,250, I give them the option to say, yes, I will do it. Because again, there's discrepancy with ultrasound in the third trimester. You could be off by a full pound. So if I say the baby is 4,000 grams, it would be 4,500. So I would give the moms counseling and let them decide about the risks, and we move forward from there. I'll make it available to them at 4,000 grams if they want. After delivery, very important. We need to reevaluate the mom very closely because she's at risk for developing type 2 diabetes. This study done very many years ago, and many subsequent ones have shown that within 20 years of delivering, if you had diabetes in pregnancy, the mother will develop diabetes, 50% chance. And in obese moms, it's between 70% chance that within 5 years, they will have diabetes. So it's very important to screen for diabetes postpartum. The problem is, like I see here, only a few people who have diabetes in pregnancy get this postpartum screening. So every mom with diabetes needs to know that they should come back between 6 and 12 weeks postpartum for the screening, okay? If they miss that window, it's okay. Whenever they show up, please test them, right? So these moms get a glucose test, like the one I talked about earlier, but this time it's 75 grams. Fasting blood sugar, and we take the sugar 2 hours later. If it's normal, then every 1 to 2 years, take them again. Tell them to do weight loss, physical activity, and get them counseling with a nutritionist as needed. If they have a fasting sugar between 100 and 125, or a 2 hour of 140 to 199, then that means that they have impaired diabetes, impaired glucose tolerance. These moms, I have them come back every year to check them again. I put them in weight loss clinic, refer them to a nutritionist, and encourage them that they can, develop diabetes if they don't change their lifestyles. And these moms, sometimes I put them on metformin, because like I said before, metformin is associated with increased maternal weight loss. And if the moms have a blood sugar fasting that's more than 125, or 2 hours that's more than 199, they have overt diabetes, and they should be managed appropriately with an endocrinologist, nutritionist, and a health coach. Any questions before I?
Okay, so Dr. Akoma, if we could just go back to your slides for obesity and just slowly walk through, change it. People might have 1 or 2 questions. I know a couple of people that joined late, and they can just read and ask the questions. But I'm going to ask the questions I have so far on the chat. And we have a question about aspirin. Yes, this is a good place to keep it. We have a question about aspirin. And the question is, give me a second to pull it up. I am curious to know whether this is standard, giving low dose aspirin, 81 milligram baby aspirin, to obese pregnant patients in Nigeria today. So Dr. Mason, if you're on the call, can you please answer that question? While Dr. Akoma, if you could answer, are there risk factors where you would advise against the use of low dose aspirin in these obese moms?
So allergy to aspirin for 1, GI bleed for 2. Those are the big reasons why to avoid aspirin. Other than that, aspirin is very, very safe. And according to, and Kendra, I'll send it to you. According to ACOG recent practice bulletin, there's a list of people who are high risk for having adverse outcomes, and low dose aspirin is recommended. And in some people who've had even preeclampsia, severe or even HELLP syndrome, we recommend giving double dose, so 150 or 160 milligrams of aspirin in pregnancy. So it's definitely standard of care. Oh, at least for now, it's definitely standard of care.
So contraindicated in those with GI bleeding, and what other condition did you say?
Allergy to aspirin. Other than that, no problem.
Okay. Can any of the doctors on the call answer the first question? Is low dose aspirin being given to obese pregnant women in Nigeria today? Okay, so I'll let people chat that in. And the next question we have, I'm going to ask you another question. Okay, so you said you're in answer to Dr. Ode's question, you will share a list of conditions where low dose aspirin is recommended. Okay, great. We have another question. And what do you do if you were not able to get a BMI in the first trimester, but in the second, but now you have a BMI that is 32, a BMI of 32 during the second or third trimester? How does that change management?
It doesn't.
Your hand, I'll call you right after this. Yes.
It doesn't change the management. So I would assume that if she's third trimester with a BMI of 32, it's most likely that she was overweight before she became pregnant, and we're meeting her too late in the pregnancy. If a BMI of 32 in the second trimester, depending on when it is, if it's 14 weeks, then okay, most likely it's obese. If she's 27 weeks, then it's a question. Either way, she was considered most likely overweight. So I would use the overweight and just backtrack as that get my in the overweight range and make my recommendations based on the pregnancy.
Okay, so I have someone asking you to repeat that but slower.
Yes, I'm so sorry. So I said we always like to extrapolate things, right, in pregnancy or in medicine, because we don't see people from start, right? So if somebody comes to me at 32 weeks, right, and their BMI is 32, I would assume that, okay, maybe they've gained some weight throughout the pregnancy, and the BMI was probably in the overweight range in the beginning, right? If somebody comes to me at 14 weeks, which is considered second trimester, with BMI of 32, then I would say, okay, maybe this person actually is obese, because only 2 weeks ago, or 1 week ago, she was in the first trimester, right? If she comes to me at 37 weeks with a BMI of 32, I'll 100% assume that it's been weight gain during pregnancy that gave her this BMI. Because even that, I'm thinking maybe she was overweight in the beginning of pregnancy, but I would use, I would give her risk factors based on being overweight, based on when she came in. Most likely she was overweight, I would assume. If you came in the third trimester, I would say definitely overweight. If you came in the first trimester, I would categorize her as being obese.
Okay, thank you very much. And I know that Dr. Musini was raising his hand. Can we please unmute, give people the ability to unmute themselves and speak? And I would call on Dr. Musini to answer that question.
Okay, well, good afternoon, everybody.
Good afternoon.
Okay, let me thank the presenter for the very fantastic and educative presentation. So quickly, in our environment here, I think it's obviously consistent with good practice. If you are managing an obese patient in pregnancy, especially if you get to see her before 16 to 18 weeks, usually here we place them on low dose aspirin. And again, it's because of observations and what we know that obese, and like has been articulated this morning, obese patients are usually, they have a higher than normal risk level to come down with preeclampsia, diabetes, And of course, if they're not properly and well managed, unexplained IUD and all of that, they try to retardate, and so many other complications. So we have available our baby pill at 75 milligram dose that a number of us will institute in our pregnant women, just as a preemptive and a preventive measures against some of these conditions I've just mentioned. Preeclampsia has become the leading preeclampsia, severe eclampsia, hypertension has become the leading cause of maternal mortality in so many settings now. So for me, I think it's a good practice if I use low dose aspirin alongside other measures, diet, exercises, and being particularly vigilant, for some of these complications. So yes, most gynecologists, obstetricians now for obese women will usually want to, place the pregnant women on low dose aspirin.
Okay. Thank you very much. And so in just looking at this summary of, if you have an obese woman in front of you, what what would you want to do before she gets pregnant, while she's pregnant, and after she's pregnant? I wanted to draw the attention to when she's 36 weeks. And you say begin ultrasound for fetal monitoring and 30 minutes of using the CTG machine to monitor fetal well-being. And if the woman is greater than 40 BMI, we should start this as early as 32 weeks. I wanted the other healthcare workers on the call, Dr. Milseni, and any other doctor on the call who wants to unmute and contribute to this. Is this what we're doing?
Well, is this what we're doing? Again, what we've just had is, again, what should be done. Ideally, if you have, a diabetic in pregnant, a woman who is diabetic or who has a very high risk, to come down with diabetes or have multiple risk factors, ordinarily it should be managed in a setting, that has a multidisciplinary approach. In other words, it should be a teaching hospital, and all that. Okay, so in a teaching hospital, you should have access to all of this. But we know the situation here. So a number of times we know what to do, but a number of times we are hamstrung. And yet we know basic things that we should do. So if we have a woman who is obese, or a woman who, has gestational diabetes, or who has a proclivity, to becoming diabetic, we do most of, what has been reeled out. And having access to CTG is becoming a lot more available now. Okay, but the truth is, to answer your question, what do? We screen, we look out for, DM. If it's there, we provide, of course, we try to get a multidisciplinary approach. We are using more oral hypoglycemics here. I'm sure at the end of the day, somebody's going to look at the safety. And that is because of the peculiar situation. But ultimately, we hardly ever, get our women, regardless of how well we think they've been controlled, to go past 38 weeks. And that's because of lack of access, to, the kind of fine control that our presenter has access to. We usually tend to err on the side of caution, and we do not allow the pregnancy to go past 38 weeks. Of course, we know the issue of delivering a woman of a baby between 38 and 39 weeks. At 38 weeks, all of that is because you have non-respiratory or neonatal, respiratory difficulties. But again, from one of the slides you showed, from about 38 weeks, the incidence of sudden IUD and some of these other complications tend to begin to, take a steep rise. So usually in our environment, especially in general hospital setups, when you do not have, a much easy access to close and consistent, maybe weekly, fetal maternal surveillance, we give all the treatments at 38 weeks. More often than not, we effect delivery in general hospital. When you have access, to much closer monitoring, you are allowed to, get to about 40 weeks here once we are sure that the control has been good, but it requires a lot of resources. And these resources, sorry to say, are not as available as we want them to be. So most I want to hold the side of caution and then effect delivery at 38 weeks. Of course, we expect what challenges could come, because if you are dealing with a diabetic, for example, at 38 weeks, the lungs most times may even play more games in terms of, lack of maturity. So, but rather than have a sudden, intrauterine fetal death, you want to bring out the baby, and having, of course, discussed with the neonatologist. At least most general hospitals will have neonatologists or experienced, medical officers who have had stints in pediatric care, to co-manage with you. So more often than not, we tend to deliver these women at 38 weeks, especially if they have, a complicating, gestational diabetes. We can't guarantee, that we can monitor very closely, and it's usually a disaster if you have a sudden IUD, and especially if you have to now do a cesarean section because of big baby failure to progress, and then you don't have a baby to show for it. So the cesarean section rate, the intervention rate, either by way of induction and other, is usually higher in our environment, and I think that is fair. It recognizes the challenges we have, but at the end of the day, you have a better take-home baby rate here, where you can't guarantee women doing their own bit, and the managing hospitals having access to all that they will need to confirm that control has been very good.
Okay, so I would like to invite any other person on the call who wants to unmute and contribute by asking a question or a comment. Dr. Orode is asking you, Dr. Moseni, do we do anatomical ultrasounds for women in Nigeria? Dr. Kayode, do I see your hand? I'll be calling you soon. Dr. Moseni, do we do anatomical ultrasounds?
Well, I think the anatomic ultrasound, we are alluding to, scan to exclude fetal anomalies, and of course to establish the biometry of the growing baby. Yes, usually, especially where you're dealing with, GDM and all that. Yes, at about 22 weeks, we do to exclude, gross anomalies. And then beyond that, regularly again to look at how well the baby is growing. That is the biometry and all that, just to exclude them. Yes, we do. We write, and again, it's also a function of the woman to be able to spend the 2,000 naira, 3,000 naira, 4,000 naira, to do a proper anatomical scan. But we insist because again, it helps us in having a good. Most times you use your tape rule, to have an idea of how well the baby is growing, but we know the confounding variables.
Yeah.
Abdominal fat, the presence of, fibroids in our women. A number of our women aren't getting pregnant, and so the issue of fibroid coexisting with pregnancy and all that. But in the final analysis, like I said, we tend to over-treat, and we not that we panic a lot. We intervene perhaps more than necessary, because we do not have access to things that will aid us, in more precise understanding of what the situation is, and so reduce panic and get us to get the baby the pregnancy to advance to a much higher gestation, where the outcome for the baby, maybe at 39, maybe 40 weeks, should be a lot better than if we were to intervene at 38 weeks. But in the final analysis, you don't want intrauterine fetal death. So if you are going to bring out the baby and then get the neonatologist to help you manage extra uterine, I think more often than not, we opt for that option, even though we know that things could be better if we could get a much higher gestational age. But hardly we ever go beyond 14 weeks here. 41 weeks, we do not have the, we do not have, that courage to go beyond 40 weeks. 38 weeks, most people will intervene here because of the reasons are earlier advanced.
Thank you very much. Dr. Kaido, if you can unmute and ask your question or make your contribution.
Good afternoon, ladies and gentlemen.
Good afternoon.
Can you hear me?
Yes, we can.
Yes,
we can.
This pregnancy is a high-risk pregnancy because obesity and diabetes mellitus is an high-risk pregnancy, and they are predisposed to having hypertension. So I think this pregnancy should be managed actively with the use of a Doppler ultrasound tool at 24 weeks to confirm the fetal anemia and others. And also, it is
I think we
better
lost.
to prepare to plan for the delivery. And then I hope they are also prone to increase cesarean section rate because of their obesities and gestational diabetes mellitus. And to my own best of knowledge, it is better and best for them to deliver at time. Thank you very much.
Okay, thank you very much, Dr. Kade, for your contribution. I want to ask Dr. Orode Dorothy, who is our hub expert on pediatrics, what considerations should be made for babies born to obese mothers?
Good afternoon, Dr. Kendra, and good afternoon to everyone. And thank you, Dr. Akoma, for this presentation, and to everyone for the very insightful questions. So a couple of things are the things that are most important. I recall that Dr. Akoma has alluded to this, that the mom has a much greater risk of, one, having a macrosomic baby, so a big baby, but they also, so a lot of the time in our environment, when we see these moms, they've tended to also be overweight. So we can also have the risk of them having small babies, but most of the time we're expecting a big baby. We expect, in addition to that, Dr. Mosemi alluded to this, they tend to be, their lungs tend to be less than optimal because, one, we tend to deliver them earlier, but two, also there is a delay in their lung maturity. So we expect abnormal blood sugar. Usually they're not able to raise, keep their blood sugar up in the early days. So we ensure we're closely monitoring their blood sugar. Many of them actually, in the early days, we used to put them on a dextrose infusion when they came out. We didn't have the ability to consistently measure in those days like we do now. So they'll be on a dextrose infusion. Obviously, you would have been worried about the size of the baby, so macrosomia doesn't help. You keep an eye on that baby because there's a tendency for macrosomic babies to not look as unwell as the tiny preterms. They almost always wish they were small so that they would get more attention. But there's this myth that the baby's big, the baby's healthy. It's not the case. If anything, they are unable to maintain their blood sugars, and you worry about that. And then, of course, the issue of their lungs not being mature. I think also that they tend to be more prone to having had an asphyxia situation because if there was an attempt at delivery. So that is certainly much reduced now that we do early deliveries and deliver them by CS. Then, of course, the issue of monitoring these babies and making sure that when they start to feed, they're not feeding up or they don't show up with congenital abnormalities, especially of the GI and of the hearts. Those are the things that we are most concerned with, first 48 to 72 hours. Once they overcome that, then we're dealing with a newborn like every other. in Nigeria, and we still have to be concerned about exposure to infection and all the other newborn issues. But they just tend to have more of these things in the first 72 hours.
Okay. So, Dr. Akoma, I wanted to bring us back to, I know that there's the medical management, but something you said was really interesting, that 85% of, these diabetes and obesity in pregnancy can be managed with diet control.
Yes.
And you spoke about the different trimesters having that expectation around how many calories, increase. And this norm we have for eating for two. So I was just wondering if you could run us through again, by trimester, what the expectation is and what that translates to in real life, because we're not used to counting our food as calories. But I know you gave us this beautiful examples, and we'll be sharing the slides to everyone on the call. So if you could just recap that.
Okay. So I was in Nigeria a few months ago, and I was reviewing with some of the people in my village. I said, let's just sit down and let's just count how many calories are on this plate of gari, right? So of course they presented me with a mountain of gari on a plate. I didn't count the soup because it was purely vegetable soup and protein. In that mountain of gari, there was 6 cups. If we measure cups of gari, right? And if that's 400 to 500 calories, that's already 3,000 calories right there in one meal. Right? That's not even my lunch or dinner. That was just the first meal that they gave me for the day. Of course, I didn't eat all that, but typically, I would say if you're eating a plate of gari with
Dr.
soup.
Akoma, can you please, so someone with the network issues and all that, we're just asking if you can just slow down a bit in your answer so that we can get you.
Yes. So typically, I would say with a big plate of gari or a big plate of rice, you already made your caloric requirements for 2 days, right? I'm just being judgmental. Average Nigerian plate that I get presented to me when I come to Nigeria to eat, right? So in pregnancy, you should not increase, honestly, even if you're underweight or regular weight, more than 500 calories per day. And in my next slide, I have here 500 calories is maybe 1 cup of beans and maybe a slice of yam, extra, right? Or 4 slices of plantain, or a banana, an apple, some carrots. But we typically eat too many calories in even one sitting. So there's definitely not eating for 2. In the first trimester and pregnancy, in obese and non-obese moms, you should not increase your caloric requirements at all. You should not increase your caloric intake. You should not add any extra foods. You're not eating for 2. Your prenatal vitamin will suffice. In the second trimester, in normal weight and obese moms, you should increase between 300 calories to 400 if you're normal weight. And if you're obese, I would say between 100 and 200 calories. But let's pick maybe like a banana per day extra, or an orange per day extra, or 1 or 2 slices of plantain, if you want to say. But in the third trimester, it's even less. 200 calories for an obese mom and 500 calories for a mom who's underweight. So that's like a cup of rice and maybe 1 plantain. So typically, like I said, in Nigeria, what I'm used to be presented are enough calories in one meal for 2 or 3 days.
Okay. And so the way we eat, one meal is over 2,000 calories already. And then for the pregnant woman who is eating more often and eating for 2, she might end up having a calorie consumption of 7,000 calories a day. And so just to draw that, this is really important, that these deliveries, management of the obese and diabetic mom is happening in a secondary level facility or a tertiary level facility where she can work with a nutritionist to tell her what to do. So Dr. Mercy, I'm going to ask you this question. What advice should healthcare workers leave this call with? The mom is sitting in front of you. She's obese and she's diabetic. How do you break down to her in very clear terms what she should do?
Well, the first thing is to recognize the fact that the health challenges, as represented by obesity and diabetes are there, and to let them know that we would have preferred that they were not there, so that post delivery and all of that should appreciate the need to look at diet, exercises, and all the other things that would help her in managing it. But haven't mentioned that is to let her know that these are challenges that will require a lot of efforts and compliance on our own part, and of course attendance of antenatal classes, so that she could benefit from basically all that we need to ensure that the outcomes are good. We have to let her know fully well that the outcomes, in terms of mother and baby, are a function of how well, again, she complies, like I said, and all that. So from the first day, there are things that we need to do, and they all border on diet, the border on needs to, do basic exercises, and then more importantly, take whatever medications, either insulin or whatever, that the managing physician would, at the end of the day, after doing the relevant tests, including, a sugar profile. Like I said, we have our own peculiar way of managing them here, again, because of a number of things. But the irony is that, most of the food types that our women really enjoy and relish in are the ones that have very high calorie. I was like deja vu, or rather, the issue of yam, the issue of rice, the issue of, just name it, diets that are high in calories, incidentally, are things. So, but for every situation, we have ways of managing them. In other words, if you are going to, go on those diets that have been mentioned that have a high risk, or a high calorie, that we know what to do in our own way. The dietitians have their own advice, they have their own rough estimate. And then, of course, even if you're going to eat rice, what type of rice? So the summary essentially is to let these people know that there's a higher than normal level of risk to the baby and to the mother in terms of the outcome. That, however, if they do their bit and they come around and we work together, and when I say we will mean the doctors, and it could be a multidisciplinary approach, which is the right thing. If, for example, you are in a primary healthcare, for example, that is not a case for them to manage. If you are in a secondary healthcare center and you do not have easy access, to the other people to co-manage with you, you refer, to tertiary center. But we know the challenge, because the further away of this tertiary hospital, from, the location of our women, the challenge of, having good antenatal care. So each institution must have a way, either use of protocols, guidelines, or easy access, to all the other healthcare providers that will help the managing obstetrician ensure that they're on top of their diet, on top of their exercises. Of course, agree whether they should be on oral hypoglycemics or insulin, and then looking at the capacity of these women to comply. We must look at it. In other words, it's very simplistic to expect a woman, to get, you prescribe insulin. She doesn't have enough money. She does not have where to store it. You understand? And then you expect her to. And then there's a woman whose best food types are EBA and all of that. So there are usually peculiar challenges that we must, in establishing a plan of care, take it to cognizance and walk them through, so that at the end of the day, ultimately, diet will find a way around it, access to medication, and then the easier and the cheaper the medication are more accessible, are more affordable, the treatment modalities, the better. We know the ideal thing, but we know the reality. You must strike a balance. There must be birth preparedness. You must let them know what they have to do. In other words, you have to call the husband. I'm not going to talk about those who do not even have, but deal with the peculiar challenge, knowing fully well that the outcome could be very unfavorable if from day one you do not have people who are in a position, to comply with all the measures that have been known to improve the outcomes. So is to have birth preparedness, good plan of care, engage them, know their capacity, where you need to help, where you need to refer to a high level of care, know that. But you have to take everything into consideration. Thank you very much.
Okay, thank you so much. We have some great contributions in the chat. Fumi Ijola, who is a nutritionist, says at our hospital, we started something we called preventive nutrition care. We identify women at ANC booking registration who are more than 90 kg. We intervene using 4 factors: controlled calorie, fluid intake, fruits and vegetables intake, and diet diversity. Fumi is going to be speaking on Saturday on practical tips to staying healthy during the holidays. So be sure to tune in to listen to Fumi, who is a nutritionist, speak on practical tips to staying healthy. Dr. Ima Debo, who is an OBGYN, is also adding that also when in labor, we have access, if we have access, we could use CTG. Given the challenges of listening to the fetal heart in an obese woman in labor, we definitely work with what we have, and ultrasound monitoring is thankfully now readily available. So, those are some of the contributions that we have. Dr. Akoma, we are almost at time, but I wanted to just, as the last question, key question, just have you show the case presentation, the key highlights of the case presentation, and we can have people answer like one question from it.
So next demo today she's pregnant. She had 3 deliveries in the past. Birth they look nice and
Dr. Akoma. So 1 minute. Ikechukwu, can you please mute? Can you please mute so we can hear Dr. Akoma clearly? Dr. Ima, you can mute you can mute everybody, and after Dr. Akoma is done, then you can unmute. So Dr. Akoma, if you can just slowly go through this, we'll appreciate it.
Okay. The math again is 32 years old. She has 3 children, and today she's 36 weeks pregnant. She's had 3 babies in the past. The first baby was very small, normal weight. The second 2, 39 to 100 grams, 4.15 kgs the second one. And those last 2 pregnancies, she had diabetes in pregnancy. And the last one, she was on insulin. The baby had a shoulder dystocia, but thank God the baby is doing well and didn't have any brachial plexus palsy. So her BMI is 45. She's had diabetes in her last 2 pregnancies and a history of shoulder dystocia. Her labs are here. This basically shows that she failed the 1 hour. Remember I said before, people use 130 or 140. If we use the 140, then we would have missed her diagnosis. If we use the 130, we'll pick her up. That's why I said arbitrarily, I think it's always better to err on the side of caution and use the lower numbers to diagnose people. For blood sugars, she's been checking them 4 times a day, fasting, and 2 hours after she eats. Very, very suboptimal. We put her on insulin. While on insulin, she's very, very non-compliant. So she's had a total of 12 ultrasounds in pregnancy. And yesterday I scanned her, and the baby is 4.25 kgs. So here are the questions for Ms. Kellas. Which one should I pick?
What mode of delivery should we recommend?
Yes, that's a good one.
So this is open to anybody on the call. What mode of, given this history, she's 36 weeks. She's had 3 prior pregnancies. The baby's weight has been increasing. She's had shoulder dystocia in her last pregnancy. The baby's weight is currently 4.2 kg. What mode of delivery do you think is best for this woman? Does anybody want to try? You can unmute. Annie, can you allow people unmute themselves?
I mean, I would try. This is already, I'm the pediatrician, so obviously I have a vested interest in getting a baby out alive. But I would, I mean, I would advise that she's Bobby is 4.25 right now, so maybe it's 4. Oh no, maybe it's 4.2. I mean, I would advise that she go to a cesarean section.
Cesarean section.
Okay. Somebody's agreeing with you, Dr. Orode.
Yes.
I'm sure the woman herself will probably, she will certainly opt for cesarean section. I've been having the experience, shoulder dystocia, and its attendant, emotional and physical effect, both on the mother and then, of course, on the baby. I'm sure the woman herself.
What about timing? Remember, she's 36
Hello?
weeks. When will you deliver?
Weeks. So
No. Well, like I said, here by 38 weeks, I think we should just induce the woman. Again, that's what we usually do here. I think by 38 we should induce the woman, and that delivery.
We do 37 because the risk for stillbirth.
Wants 37. She wants her baby alive. So the pediatrician in Dr. Orode is voting for 37 weeks.
Wait, I remember this. I told you this.
No, whether 37, 38 weeks, I think the most important thing is that you don't want that woman to stay to 40 weeks. I think that is so for me, I won't want her to go past 38 weeks. So between 37, 38 weeks, we are fine. Again, if you permit me, I just wanted to add that, in preparing for, vaginal delivery, it's very important, especially given the nature of our setting here, to ensure that you have a doctor, an experienced person, and to conduct and take that delivery, if possible, the consultant. Because evidence has shown that even where you do not have, a baby of a diabetic mother that is about 4 kilograms, at birth, for as long as DM is there, the risk of shoulder dystocia is, even if the baby is weighing 3.7 kg. So one of the things I usually teach my resident is that simple macrobot maneuver, about how to hyperflex the thigh, and so that when you're beginning to experience what looks like a shoulder dystocia, I mean, that is a maneuver and a procedure that in close about 80-25% of cases, and it's very easy to learn, will help you navigate and get the baby out smoothly. So 2 things. Yes, once the baby is way more than 4 kg, either by way of clinical estimation or by ultrasound scan estimation. And don't forget the notoriety, of scan in the 3rd trimester to give you false value. So the thing is to assess and then prepare, anticipate, shoulder dystocia, and ensure, and it's very key here, that whoever is conducting that delivery has the requisite skills, to navigate if you're not doing a cesarean section. Come often than not, you have inexperienced people who don't even anticipate. They don't know how to do the simplest of maneuvers that has been shown to be very helpful in not giving Dr. Orode babies that have all the brachial, plexus injuries and all of that. So for me, if I have an obese patient or a diabetic patient, usually I write out the risk, what should be done at 34, 37. I agree that the baby should not be pregnancy, perhaps should not go beyond 38 weeks. What route of delivery, who should be there? And then more importantly, inform the consultant if the woman is in labor, if the agreement is that, a vaginal delivery should be achieved. Because you know the setting, you may need to come and take the delivery. But these are things that determine outcomes, and of course, if you are doing a serial section, again, it has its own challenges. But more often than not, if you can achieve vaginal delivery, it is better for the mother and ultimately the baby. Let me just ask Dr. already, do we believe that, because our women do not establish lactation very early, is there wisdom, for example, in saying that, okay, this will maybe units of a diabetic mother, especially given their tendency to have hypoglycemia and jaundice? There are some of your colleagues who say, okay, listen, because you can't monitor, because you can't settle, why don't you put them on artificial formula, milk for 1-2 days? I don't know your opinion on that, please, Dr. Rodi.
Thank you, Dr. Emosemi. I actually don't agree with it. I still, because what we have found is that those very babies, once a baby starts to use the nipple of the bottle, then it becomes even more difficult. So if you think about a mother who just had a CS and her excuses, or my tummy is hurting, I want the baby to continue to suckle, but we can give the baby IV. I want the baby to feel the need to suckle at the breast. And unless the baby is sick, and in that case, baby is not going to take anything orally anyway. Okay, so I'd rather have baby suckling at the breast and then keeping the blood sugar up by giving something intravenous to keep that up. And keep monitoring that sugar. I'm not a fan of giving the artificial milk at an early age, unless we know this mother is just not going to be able to nurse this baby. Mother is too sick. Mother is, we're battling for her life. Then that's no longer a priority. But if a mother is up and she can sit out and she can put the baby to breast, I don't care how much is coming out or not coming out. Nobody establishes perfect lactation anyway until something like day 3 or 4. Why do you want to confuse the baby? I would just give a bit of dextrose water and allow the baby to come up.
Okay, so very interesting discussions. I would just ask us for an extra 5 minutes as we wrap up. Our midwife hub expert, Mrs. Okalawon, is saying, why subject the poor mother and the baby to go through all the process of the manipulations during the SVD when the CS can just do the magic? So that's some food for thought, just with the attendant risk. But we'll just want to, Dr. Orede had already started answering the very key question, which is the last question. This woman still wants more children. What do you advise she does to optimize her health for the next pregnancy? And Dr. Orede has chatted in that contraception till when she's ready, and then she should definitely lose some weight. So we're going to, at this point, just launch our post quiz, because again, remember, Dr. Akoma is 6 hours behind us and has to get to work this morning. And so we're going to launch our post quiz. And please, we want people, even if you didn't take it at the start of the call, feel free to take it again, to take it now. You see it on your phones, on your laptops, and it is 1 correct answer per question. Yes, Mrs. Okalawon is saying this woman before the next pregnancy definitely needs to see and work with a dietitian. Very true. So it's, please feel free to answer the question. Kubwa General Hospital, thank you for joining, is saying in their facility, be it diabetics mother or not, it is if the anticipated weight of a fetus is equal or greater than 4 kg, that mother will be booked for elective CS with the pediatric doctor and anesthetist around. As baby is treated as preterm baby, let alone the diabetic mother. Okay, so she feels CS is key. Dr. Merceny was giving the option of, sometimes cost is an issue, sometimes the God forbid factor. We advise these mothers, they don't agree for CS, God forbid, it's not my portion. Rather than lose that mother, can we, with experienced hand, try for an SPD? And of course, I'm sure Dr. Merceny will say his first recommendation will always and always be the CS. So thank you to all those who have started submitting. Okay, go ahead, Dr.
No,
Merceny.
Dr. Merceny will say, Dr. Merceny will say the first recommendation, of course, will always be vaginal delivery if it's
really?
safe for both mother and baby. Yeah, that's the truth. And that's the standard. In other words, if control is good, see, don't forget that one of the challenges we're having right now is having to grapple with, the complications, or rather the challenge of increasing cesarean section. Our women here, we're pronatal here, we have babies here. All the problems of repeat cesarean section, all the problems of, morbidly adherent placenta, maternal, and of course, okay. So in other words, if we can achieve vaginal delivery, so be it, let the indication for cesarean section emerge. Macrosomic baby is one, okay. So the crux of the matter is the challenge, ensure that the control is good. If the woman comes in early and aim to achieve vaginal delivery. The woman who is diabetic, for example, and undergoes cesarean, thank God for spinal anesthesia. In those days when we had the general anesthesia, you had all the issues. She could have all the complications. So the standard where it is possible and is available is, where the control has been good, induce, get an experience and get the pediatrician there. But once the indication for cesarean section, so be it. Because once you scare that woman, I can assure you that in subsequent pregnancy, it's going to be GDM plus previous cesarean section. And our women, our culture, we want to have 2, 3. Especially if we do not have the gender balance as it's where we do respect to everybody. So one way to avoid, increase cesarean section rate is to ensure that the first time you try to achieve vaginal delivery. But let me make it quite clear, the woman, more often than not, will earn indications for, cesarean section based on obstetric indication.
Mm-hmm.
You understand, But what is more important is for everybody the managing team to recognize that it's a high risk. This is not, with due respect, a delivery that should be conducted by, experience and
Yes.
more often than not. But once you have a baby, cut off 4 kilograms and above, except of course where the woman herself is capacious, and then, you probably want to deliver by cesarean section. But I don't want it to be a rule or to be seen as a rule. I want it's diabetes, even where you have achieved very good control as evidenced in 1, 2, 3 things: the weight of the baby, compliance with medication. Why not induce the woman? The advantages are there in that pregnancy for both mother and baby, and in subsequent, pregnancies. More so when the woman will have the opportunity in between pregnancies to lose weight, get very good care by, maybe the diabetologist, exercise, get properly prepared for the next pregnancy. So that again, because once you section, you can't induce subsequently. It's going to be a cesarean section. Okay.
You're
and
right.
our society, the average fertility. Exactly. So what I've just said is standard. And I think that's the way it should be looked at, really.
Thank you for that clarification. We have about 30% of people who have submitted the poll quiz. So I wanted to sneak in this last question, and I'd like any of our hub experts to address. So we conducted a survey, mDoc conducted a survey last year, May to June, across Abuja for over 600 women in Lagos and Abuja, semi-urban, urban areas, rural areas as well, women of reproductive age. and 40 to 60% in Abuja and Lagos were overweight or obese. And these were women who had even never been pregnant. They hadn't started their pregnancy journey, or were currently pregnant or had had babies in the past. Now, we're wondering, how realistic is it to refer to the tertiary hospital, given the high prevalence and, you know, the load on the tertiary hospital as well, for oversight every single woman, you know, due to this increase in BMI preconception? And then the second part of that. Okay, go ahead, Dr. Emerson.
Okay, I thought the question had ended. I was just going to add that obesity is a risk factor. It is, you know, to developing some of these complications. But it does not mean that you're obese, you wouldn't necessarily come down with, you know, with diabetes or even macrosomic baby, especially if recognized early. But the truth is, with obesity, you need to be sure that the woman does not have a coexisting or a coexisting diabetes mellitus. And that is why anybody with a, you know, with a booking weight more than, you know, 90 kilogram, or a BMI, you know, greater than 30, for example, it's an indication to establish, you know, her glycemic nature. Does she have IGT? Does she have frank diabetes? If she has frank diabetes, for example, and is a PAC, you must let her know why the management of that care, of that pregnancy, cannot be in the PAC. So in other words, the weight itself, which is rising, and understandably so, diet and so many other things, lack of exercises, it only means that you need to subject that woman to further screening to be sure that she doesn't have any other medical complications at that level, or even before pregnancy, that would make you want to refer her, and justifiably so, to a place where she can get a high level of care, particularly if you are seeing her at that primary healthcare level. All right, so that you're obese does not mean that you're diabetic. What it means is that if I screen you, you are not, I can manage you, but I'll watch out. At 28 weeks, between 24 to 28 weeks, I will repeat. Or if before then you are spilling, you know, glucose, especially before 16 weeks in your urine and all that, again, I will rescreen. And once I establish that there's a problem, fine. But even if there's no diabetes, diet alone, exercises, if that woman complies, could still help, you know, improve the outcome, even at that PSC level, if she's not diabetic, nor have, you know, some other complications that would require. But that is a case you need to monitor very closely at booking, if early, at 28 weeks, between 24 to 28 weeks. So you look out for, those are the same people that will have issues of blood pressure, DM proper. So you have to be very vigilant. Once some of those things spring up, you can refer. And if you start your low dose aspirin, you may even delay the onset and all that. So it depends on where, but it's not that once woman is obese, you have to refer her. It just means that you have to look out for some of these complications to ensure that they're not there. Or if they are there, catch them very early and refer to the appropriate level of care if we do not have, you know, the...
Okay. Thank you, Dr. Misu. I'm going to ask the second part of that question. Oh, sorry, I thought you were done. I'm going to ask the second part of that question to Dr. Akoma. In the same survey for the same group of women who had about 60%, who were 60% obese or overweight, we found 50% of this same women also had anemia. So we have the double picture, the double burden of obesity, but anemia within the same subset of women. Are there additional considerations with obesity and undernutrition in the same woman?
Yes, definitely. So I would say over caloric intake, but undernutrition. So a lot of the times we're not eating things that have high iron or other vitamins. We're eating things like dairy or rice and stew. But to get iron, we need things like broccoli, meats, beans, And those things may be quite expensive. So there's lots of times where the mothers are eating, like I said, plain things that don't have enough nutrients, micronutrients, but they're making them feel full. So obesity and anemia definitely come hand in hand, especially if there's poor micronutrient or micronutrient deficiency. And that's a problem because a lot of our obese moms have increased risk for postpartum hemorrhage. They bleed a lot after the delivery. They have macrosomic babies. They have uterine acne. They hemorrhage during the time of delivery. So anemia is something that we really need to pay very much attention to during pregnancy. Treat them with iron, adding vitamin C and calcium to help absorb the iron better, increasing the iron dose maybe even twice a day with vitamin C and calcium to help absorb it better. And then after delivery, being very vigilant for uterine acne, meaning draining the bladder well, doing good fundal massage well to reduce the risk for hemorrhage, because anemia is a complication.
Thank you. Thank you very much for bringing that home, that we are taking a lot of calories, but also very, calories very low in nutrition. And so we're having the undernutrition as well, and pointing out those practical tips that can, prevent bleeding, which will exacerbate the anemia, after delivery. So again, lots of iron, check the iron, double dose iron, taking vitamin C and calcium to help in the absorption of the iron. Thank you very much.